I remember laying in hospital with thinking, okay, so you've got new limbs and you're now an action man, aren't you? You're a human action man, really. And I thought, how am I going to do this? What am I going to do in my life? And I thought, if I've got to adapt my house, and I'm a builder, maybe, and ding, the light came on. And now I'm an access consultant, I help disabled people. But from that journey, from that day one, never did I thought there was a reason for doing this. So, I am pleased I got through it all.
In the United Kingdom, there are approximately 250,000 people living with limb loss, either due to amputation or as a result of a congenital condition. And each year, there are some 6,000 new patient referrals to the NHS Artificial Limb Services. Of these, lower limb amputations account for over 90%. But regardless of how many people lose a limb, they have one thing in common. They never expected to find themselves in this situation. Part 1 is about the amputation and the first few days that are spent in hospital.
The reasons why we would commonly perform an amputation are for infection in the foot, which is usually due to diabetes, or for peripheral arterial disease or furring up of the arteries, where the blood supply to the foot is compromised and gangrene can set in. Other reasons would include trauma and bone cancer, but those are done by the orthopaedic surgeons and are probably not as common as the diabetes and the peripheral arterial disease.
I think people who require rehabilitation actually have very complex needs, and for someone who's experienced limb loss, really the rehabilitation process should ideally start before they've even seen a surgeon. That's not always possible, but where possible we do try and see the patient before they've had an amputation, and we offer an in-reach service where our counsellor or our senior specialist nurse will go up to the ward to meet the patient beforehand, or I would like to see the patient beforehand with a referral pre-amputation, so I can talk about what's going to happen, what their experience is going to be like, and what the future is going to offer. So in order to coordinate it properly, we'd like to see them before and then as soon as possible after they've had any surgery.
The commonest sort of story, if you like, of someone who's coming up to an amputation is they may be admitted as an emergency from the community. Either the podiatrist or the general practitioners alert us that a patient has infection in their foot. The foot's become swollen, red, the patient may be feverish. This is in a diabetic. They come in as an emergency to the hospital. We treat them with antibiotics, and at that stage it may be apparent that some of the foot is so infected, the infection's got into the bones, that part of the foot has to come off. The assessments we carry out are x-rays to look at the foot to see how much of the foot is infected, to see how much we have to cut away to get back to clean, healthy tissue. And also we want to look at the blood supply to ensure that the circulation is sufficient to heal up a wound. There's no use making a wound in a foot getting back to clean tissue if the circulation is inadequate to heal it. So we would scan the arteries with ultrasound to see what the blood flow is like, and if necessary, carry out manoeuvres to improve the blood supply. If all those measures fail and the infection continues, then the patient is facing amputation. Most patients can be awake if they want during the operation. A general anaesthetic is quite common, or you could have an injection in your back called an epidural to numb you from the waist downwards. That can be with or without sedation if a person wants to be just not aware of what's going on. The operation itself takes about an hour, but the anaesthetist would require half an hour to an hour set-up time. So the patient will be in the operating theatre for about 2 hours altogether. Once the operation's done, they're around in the recovery area for half an hour or so, whilst we make sure that all their observations are satisfactory, there's no ongoing bleeding, and that everything's all right before they go back to the ward. One of the considerations before an amputation is what level you're going to carry out the amputation. If the blood supply to the calf muscle is reasonably good, but it's the foot that's the problem, then you can amputate below the level of the knee, if the knee is in good condition, of course. If it's unlikely that a person will walk afterwards due to lack of strength, other medical problems and so on, or if the knee is no good due to arthritis, it may be best to perform the amputation through the knee or even above the knee. The commonest amputation that we carry out is just below the knee, and you have to leave what we call a stump about that long in order to fit into the socket of the artificial limb afterwards. Patients often ask, well, why can't you take it down by the ankle and then you've got a length like that? Well, the further down the leg you carry out an amputation, the higher the risk of the wound running into trouble is, because the blood supply gradually gets poorer as you go down the leg. And it doesn't actually confer any advantage to limb fitting to have a stump that's longer than that. You just need that stump to fit into the cup of the prosthesis. It's a bit harder getting someone fitted up after an above knee amputation. The prosthesis is bigger, it's heavier, the patient has to be fitter in order to walk successfully with an above knee prosthesis, but if a patient's strong and determined, then they will walk with an above knee prosthesis. The through knee amputations tend to be done for patients who we don't think are going to walk. If they've got a good blood supply to below the level of the knee, but we don't think they're going to actually walk, if you do the amputation below the knee, what they tend to do is that the stump goes into a fixed flexion. They tend to sit with their knee bent, and it can get stuck like that, and then the stump just rubs on the bedclothes and they end up with a pressure sore on it. So it's better to take the amputation through the knee, so that they've got a long lever to sit in the wheelchair, hitch themselves around the bed and so on.
I've had my amputation because I had a condition called Berger's disease, or Berger's syndrome as I like to call it, which affects the smaller blood vessels and the extremities of your limbs. And it got worse and worse over a period of about 2 years, to an extent where the pain was extremely bad in my foot. And in fact, the end of my foot was dying off. And so the best option for me was to have the amputation. Although in so saying that, the doctor at the hospital, the vascular surgeon, did in fact try various things on me for a period of about 4 weeks to try and alleviate or to get the blood flowing in my lower limb. But I think I knew right from the outset, and he had told me that the outcome would probably be an amputation. And so I prepared myself to a certain extent for that.
Quite a common comment from amputees is, I wish you'd done this a lot sooner. They may have been festering along, if you want to use that expression, with an infected foot for quite some time, and it's been dragging them down. Then they have their amputation, they suddenly feel a lot healthier. They've got a useful artificial leg, and they can get on with their lives without constant dressings and so on, and infections and antibiotics and all this.
Well, I've been a diabetic for about 20 years, and I was working in a hotel, and I noticed that my feet were starting to walk like that. When I went back to the doctors, he said I had something called Charcot's feet, which is common in diabetics. And I had my legs in plaster and calipers for about 2 years, and they said, you know, maybe you should give up chefing. And what happened was, on my left leg, I had an ulcer that wouldn't heal. And as it got worse, it got gangrenous, so I had to have a below-knee amputation. But I was in one way it was a relief, because I was in and out of hospital for about 4 years, having the ulcer debrided. I spent 2 Christmases in there, and even on New Year's Eve, even in New Year's Eve, the nurse wouldn't give me a sherry or anything like that. And it was being treated every 3 months, and daily dressings, and in the end I felt that was the best thing, and I feel a lot better, and I was able to go back to chefing, which is pretty good.
So it was a bit of relief then for you?
Yeah, after like 4 years of, as I said, I had long leg calipers, I had moon boots, I had legs in plaster, and crutches and everything for nearly 4 years.
In the Portsmouth and South East Hampshire area, amputations are generally carried out at the Queen Alexandra Hospital in Portsmouth.
When they first come in, the nursing staff will take them into their bed area and they'll do their observations, they'll take all their details of their next of kin and their address, sort out, find out about where they live and whether that's going to be suitable for their discharge. They'll be seen by an anaesthetist and the surgeon, and obviously the operation will be discussed with them and any questions that they have will be answered. And if they need to be seen by a counsellor, because obviously it is quite a traumatic experience on some occasions, then the counsellor can be arranged for them to come up and see them as well. When they come back from theatre, they do come back with an epidural for their pain control. They'll come back with a drip. They'll possibly come back with oxygen on. They'll be seen by a nurse every 15 minutes to half an hour and have their observations done, which is just keeping an eye on making sure that everything's okay and their pain is under control. They will be able to eat and drink when they come back, and but they will be on bed rest for the first 24 hours, so just to keep them comfortable and make sure that the wound is okay prior to the surgery, post-surgery. And then after the first 24 hours, they'll be seen by the physio and the nursing staff, and they'll think about getting them up into either the chair or at least onto the edge of the bed to start with.
I mean, I must admit that even though I said yes, I wanted the amputation, that first day I couldn't bear to look at it, and then said to myself, don't be stupid, pulled the covers back, said, right, there we go. And then, as I said, my daughter came in and she'd actually bought me a pirate's outfit. So I dressed up as a pirate, I had the parrot, the eye patch, the lot, sat in bed, waiting for the nurses to come round.
The first relief post-theatre is the epidural. The epidural is put in specifically to help control that phantom pain and to keep their pain well under control. People experience it in different ways. It's where the nerve endings have been cut and the patient is still feeling that their leg is still there, and they could still experience the pain that they may have had prior to surgery. We have a pain team which will come and see them on a daily basis, and they will suggest certain drugs that can help control that phantom pain. Generally we start them about the 24 hours, 48 hours after the surgery, and especially when the epidural comes out.
I mean, my main thing was, I would say, sensation.
Yeah.
More so than pain.
Yeah.
I would say, touch wood, I've been quite lucky in that respect. I mean, I know directly after the operation, I found it quite weird that I could feel my leg going through the mattress. It just had that sensation that it was going right the way through, and you think, this is good.
I do remember that.
And it wasn't frightening or anything. It was just this sensation of thinking,
unusual.
I can do this.
Unfortunately, there's no respite. You don't have a few days off in this process. We like to see the patient straight away post-op, so in other words, the next day. And the amount of work the patient can do varies, because some patients find the anaesthetic does make them feel pretty poorly the first day. We like the patient to be able to move around the bed, even if they're not able or they feel well enough to get out of bed that day. We would like them to be up and sitting up in bed and being able to roll, and that helps prevent problems such as pressure area deterioration, pressure sores in other words, and problems with circulation. So a lot of the stuff we do in those first few days is to help the patient get over the effects of the anaesthetic and prepare their way for getting up and moving again. If the patients are well enough, we would get them out of bed the first day, which sounds a bit shocking, but it's actually very beneficial.
Mine was trauma, so it was very sudden. And I guess my first thoughts were fear. It's a life-changing experience, and it happens in a split second, and it's scary. Mine was from a motorbike, and I was laid in hospital, and then there was a bleed. Long story short, so I was told, lose the leg or lose my life. And of course, at the time, you just go with the life bit, but then when you wake up, that's when everything hits you about your life and what you're going to do. And I was petrified, and there was very little information, there was no one to talk to, and I just didn't know where to go from there.
The rehabilitation process that follows amputation starts while you're in hospital. In part 2 of One Step at a Time, we provide information about the rehabilitation care that you can expect to receive whilst you're in hospital. It is also about the support you receive in order to get you home and ensure your health and safety. Dee Humphreys and Juliet Kite are senior occupational therapists based at the Queen Alexandra Hospital in Portsmouth.
So we meet with an initial assessment with patients on the wards hopefully soon after they've come into hospital or after their operation. And we meet with them and maybe with a relative or the wife or someone to discuss. Basically, we'd like to find out a bit more about them and about their home situation particularly, and what's led to their amputation, and sort of the beginning plannings of thinking about going home and also the future. So we try and find out about your home environment, your mobility beforehand, and starting to think about going home in a wheelchair, as that will be necessary after the amputation.
Hopefully when we've met the family and the patient on the ward, then we try and arrange the access visit. That's the most important thing. And the access visit involves usually 2 of us going out together to the patient's property to look at wheelchair access. And we always try and do that in 2s in case one of us is off sick, so 2 of us get to know the person's sort of home environment quite well, meet the family there, take a wheelchair around and identify what the potential problems are going to be. We measure furniture heights and things like that, look at access in and out of the property. And then when we've done that, we go back to the ward, meet with the patient, come up with a list of problems if there are any, and come up with an action plan. And then we need to talk about consent and whether they're happy for us to go ahead with that plan. We try and do that with the patient.
After we've done the access visit, we've got a plan. We work closely with the physios on the wards to maybe aim for the goals. If it's necessary, the patient needs to be at a certain level before they can go home. Obviously, we would look at that, looking that they're independent in their wheelchair, working to see whether if there is any adaptations that are needed for home, whether those are small or if they're small adaptations, things we can get done, simple like rails or anything like that to get home. If there are going to be more major works needed at home, then we'll work with the social services occupational therapy service to look at long-term adaptations of ramping maybe or stair lifts or such like. So we work closely with those. Those obviously don't happen as quickly, but we can start them going anyway. If unfortunately there are some situations where home is not going to be an option again for somebody, and we can look at working with the housing services and the different councils to look at rehousing or new options for people. We've got access here where we have got a kitchen and some other rooms, bathroom, that, and we can sort of mock up things if there's things you need to practice. If you're going to be going home and you live alone and you want to practice cooking or using different things, we can work on that. We can practice those. We can practice maybe your personal care or how you're going to access your toilet, your bath, your sink. If you're going to need any equipment things, we can identify those whilst you're in hospital, ready for home, and thinking about your options there. So we can do that between the ward, and we've got a unit in our rehab block here. And basically to sort of prepare for home, sort of practice those things so that you might feel a bit more confident when you do go home.
Generally, we carry out a home visit before someone's discharged, ideally, because you don't always know if you're going to come across any problems. But occasionally, if an amputee's, we know they're very good and the home situation's ideal, then sometimes we will do a day of discharge visit. But generally, as I say, it's an assessment where we take the patient home for about an hour. Again, 2 of us go with the patient and any relatives or carers. And we get them to manoeuvre the wheelchair around the house, try all their transfers off different height furniture, and try and carry out as many sort of tasks as they would do as they went home. It's not going to be a perfect assessment because you're not there for a whole 24 hours, but it's just to get an idea about whether they're going to manage the basic essential things. Can they get on and off the toilet? Can they get off their bed, on and off their chair? Can they get into the kitchen? That kind of thing. As I say, if it's a straightforward home visit where the home environment's great and the patient's very able, we'll often leave them at home because a lot of our amputees don't want to come back.
We generally will contact all patients soon after they've gone home just to find how things are going and just to check that they have been happy with any equipment we've given and if they're happy to manage the things that they do. If there's some issues there which they need to be seen, we would obviously come out and see them at home and sort of deal with those issues. And we stay involved for as long as there are any active issues, so that whole time, the things we can keep helping with, we try and stay involved. if a patient is going to be attending the DSC to do limb training, then we generally take a bit of a back seat and allow the physiotherapist there to deal with the current issues, and they'll involve us if they think there's something we can help with.
I think for me, I mean, when I had my leg amputated, I had the prospect of losing my job, because I was in a profession where I had to be active, and so I had the prospect of losing my job, which I'd been in for almost 20 years. And for me, that was actually quite hard to overcome. But I think with the help of my family, my close family and my relatives, I overcame that, because once I got over the prospect of losing the job, in which I finally did lose my job in the October of the same year, I went on to do better things, as it were. And you just have to get on with it. You just have to get on with life, otherwise you can just sit down and fester away. But I think that was the biggest thing for me, was losing my job.
So we would need to do lots of strengthening exercises. And as I said before, a lot of patients will feel quite weak and unwell because of the disease process that's just taken place, the reason why they're coming to hospital, and they haven't been able to be their normal active self. So to build that exercise tolerance up will take a few weeks. So we can use all sorts of gadgets. We can use weights to help improve upper body strength. We can use big thick elastic bands called TheraBand, which builds up the muscle. So to help with upper limb strength, we might use some weights. So we do all sorts of different exercise patterns that will help build up upper limb strength. And these weights are all different sizes. So at the moment I've got a 2 kilogram because I'm not very strong. So we might do some work on triceps, we might do some work on biceps. We'll do all sorts of different patterns of exercise. And the patients can keep these by the bedside so that they can actually exercise when the physios aren't there. So they should be given a program of exercises for both the upper and the lower limbs to get them nice and fit. The other thing we often use are TheraBands, which look a little bit like this. They're all different strengths, so this is a sort of medium strength, and we can do exactly the same type of exercise that we do with the weights. Usually from about day 5 to about day 7, depending on how comfortable the leg is and how the wound healing process is going. We can use a thing called a PAM-aid, which is an early way of getting people up and around.
Was it the PAMO they called it?
I had a PAM-aid on this leg, because the leg wouldn't heal. It was like wearing a scaffold pole. Scaffolding, wasn't it?
Did you think when you put it on, my God, if this is what artificial legs are,
yeah, but
I don't think I'll bother.
I know, but I had one that looked nice, and this thing, I thought, a bit of scaffolding on that side didn't really look nice, did it? No, I agree.
And this is a PAM-aid, and this can be put on a patient right at the early stages of recovery, so even while they've still got stitches. And this will help reduce swelling in the stump, it helps get their balance corrected. And we like to use this rather than standing on one leg. We can do a bit of standing, but that tends to alter the way the body perceives its centre of gravity. It might alter their centre of gravity and your balance is a little bit askew. To begin with, the patients tend only to take a little bit of weight through this. And then as they get more comfortable and their stump is a little bit tougher, we can wean from the parallel bars to frame to crutches. So that works quite nicely. Unfortunately, not everybody suits this. Some people's stumps are a little bit short. Sometimes it's a little bit too tender to start with, or the wound isn't quite readily healed to enable us to use it at that early stage. But that's something that can be picked up later on. And most of the patients are given the opportunity, and a referral is made to the Disablement Services Centre. We're very lucky here in Portsmouth to have it within our city, so the patients can actually be referred and they'll be assessed more fully by the team down there as to the suitability of whether they will be okay to start walking again and when they can do that. So in the meantime, there's a little bit of a gap, so we need to make sure that the patients stay fit and well at home. So we have the community services we can refer to, and that means that the physios will visit the patient in their own home. We will make sure they've got their discharge plan of exercises to do, so they know what they can be doing in the meantime, and they can go to the Disablement Services Centre and go straight from hospital within a week to 2 weeks. There's only a small delay, and then start working down there even before their limb is ready.
facilities that are available today and the help are far greater than they were in my day. And sometimes I feel a bit jealous, really, because there is so much today to help people with disabilities. And you've just got to look around this centre. All the technicians and the limb fitters, they're all very, very helpful. We might have our disagreements occasionally on little things, but generally they're good. And the service is good, probably better than some areas of the National Health Service. Well, that's how I found it anyway.
The Disablement Services Centre, or the DSC as it is often referred to, is situated at St Mary's Hospital, Portsmouth, and provides a regional artificial limb service to the people living in Portsmouth, Southampton, Hampshire and parts of West Sussex and Dorset. It is one of 40 such centres across the UK. The assessment for the artificial limb is done at the DSC. Clinics run from Monday to Friday all year round for both adults and children. The facilities at the DSC include a gym, men and women's fitting rooms, a courtyard garden, waiting area that includes children's play area, tea and coffee and an information point which contains a range of useful information. There is also a fitting room especially for the younger patients. Dr. Mike Homer Ward is a rehabilitation consultant based at the DSC.
Rehabilitation is actually a process itself, it's not actually a treatment per se. And rehabilitation, of course, involves a lot of different people, from doctors and nurses to therapists and engineers. So as a process, it's actually quite complex. So one of the roles of a rehabilitation consultant is not only to provide medical treatment for people who need it, but it's also to act as a coordinator so that all of the services that are involved are brought together and coordinated properly. Well, at the moment we try and get them to meet as many people as they can without overloading people too much. So the important people are definitely myself as a rehabilitation consultant, because a lot of the medical needs do have to be addressed first. And then they will typically meet the nurse, the prosthetist and the physiotherapist, and quite often now our counsellor. The early 12 months is the most important time, and they're likely to see myself a couple of times, certainly at the initial consultation, and then during the year when I can assess the progress that they've been making with physiotherapy and ongoing treatment. Other than myself, they are likely to see their prosthetist quite a bit, and also their physios who are helping them with their gait retraining and other aspects of physical input that are required. So a typical person would probably expect to be seen several times during a year. It may even be as much as sort of 10 to 20 times. After that it sort of tails off, and it depends on ongoing need. We like to see children a bit more frequently because of the growing aspects, but adults that have made a successful return to walking and maybe have gone back to work, to their family life, they only need to come in as and when they want help and support. Some people, of course, are not suitable for actually using functional prostheses, and these sorts of people are tending to be older adults who are already more infirm and who have poor mobility before their amputation. Some adults have different problems, such as respiratory disease or cardiovascular problems, that are also reasons why they are going to be unlikely to be able to be physically fit enough to use a prosthesis. There's a degree of fitness that you need to have yourself to be able to use an artificial leg, because although it is a manufactured device that we keep as light as possible, it does depend on where the amputation has been done as to what sort of joints need to be replaced. And obviously the higher the amputation, the heavier the leg is, just as a natural process. So the body has to be very fit to compensate. Sometimes people think that the leg will do the walking, but in actual fact people have to use their own body and the strength and the power that that has in order to operate it effectively. And for some people that is too much. If we are in a position where we might want to work with someone and agree that they're not suitable for using an artificial leg, then some people may benefit from a cosmetic replacement, which doesn't have any function itself, but can restore the look of people from a cosmetic point of view, and this may be an acceptable thing to give to some people, but it's not suitable for all.
So on discharge, patients are referred here to physio at the centre or in the local area. We take patients from our region, which is Portsmouth City, Fareham Gosport, Havant, Emsworth, Petersfield, and obviously locally in Portsmouth City. Being referred here, there may be a little bit of a wait before assessment here. Just depends on the number of patients we have and the availability we have for physio time. But it's not a long wait, it's not a long waiting list. I would say our maximum is 2 weeks, but it can vary throughout the year.
Initially, physiotherapy is involved in the assessment process for an artificial limb, and so patients would come and we would go through looking at your range of movement and looking at your strength and working towards building up your ability and your mobility so that you can start considering having a prosthetic limb. Once you've gone through the process of being cast and working towards having a prosthesis, then we look at working on your mobility within the parallel bars, looking at balance, progressing on to walking around with any particular walking aid, and then integrating your prosthesis into your daily life. We would aim to for people to come for physio twice a week. If wounds are not healed, then it may be that patients can be doing exercises and physiotherapy at home and just come to physio once a week. It may be that if more intensive physio is required, then that can be looked at as well, but it would depend on each individual.
Initially I was below knee, so the fitting of the leg wasn't as difficult as above knee amputees. However, it was a difficult process to go through to get used to it, because you did to a certain extent have to learn to walk all over again. But once I'd arrived here, everything was explained to me right from the very, very start. So I can't fault any of the care or the knowledge that was imparted to me whatsoever.
In physio we have what we call early walking aids. For below knees, that's something called a PAM aid. Some people call it the Iron Maiden, some people call it the inflatable leg. It is a strange device, but it will allow somebody to get upright and walk in the parallel bars before they get their artificial leg. So it will help with the walking. It also helps with controlling any swelling that there is after an amputation, and can give somebody a real boost to for their motivation, really, because they're upright and they're walking. For patients who have had an amputation above the knee or through the knee, there's something called a femurette, which is, we call it a practice leg. It's like having an artificial leg and will allow, again, a patient to be up and walking, allow them to practice how to put it on and take it off, how to stand and balance in it. And all of these are used not just for practicing before getting an artificial leg, but also for assessment as to suitability for an artificial leg.
Once they are made an artificial limb by the prosthetist, you'll then bring that artificial limb to physiotherapy, so you can't take it home straight away. It's important that you go through the learning process of learning how to put the leg on and take it off again, learning how to check the stump to make sure that there are no blisters or any problem areas, and then progressing on to learning how to walk and take weight over the prosthesis. And initially it's really difficult to take your full body weight onto the leg, and so you need time to build up your confidence and to also help harden the skin around the stump. So we start in the parallel bars, gradually building up weight, having a look at the walking pattern and trying to get that as near normal as possible. And then once you start working in the parallel bars, you can then start looking at different walking aids to help you move outside the parallel bars and also into more community settings.
You had good support from family?
Yeah, very good. You know, they're amazed at how quickly you can progress, and especially when you've got a wife that says, "Have you done your exercises? Have you done that? Have you done this?" And you think to yourself, "Yes, I've done it." Your memory. You better do another lot so I can make sure that you've done it. Yeah.
A good gait's really important because it reduces stress on the other joints of the body. Reduces the risk of getting rubs on the stump, particularly reduces the possibility of getting back pain, and also if you have a good gait you've got a better chance of actually walking without any walking aids.
One other also thing to add about good gait is that the less gait deviations you have, the least energy or the less energy you need to use. And so the smoother your gait pattern is, the easier it will be for you to walk further distances before getting tired. So if you think about the amount of time that it would take to be able to be walking around again after an amputation, it is really variable from patient to patient and can only really be considered on an individual basis. But if sort of thinking about it more generally, it can take anywhere from 6 weeks post-casting for a below-knee amputee, right the way up to 6 months to even a year for an above-knee amputee, depending on lots of factors that occur during the process, depending on wound healing, and also general progress through rehab.
I don't know if everybody else is the same, but I always say to myself, I have to think every time I take a step.
Yeah. Yeah.
Whereas with people with able-bodied people with 2 legs, they don't think about that.
No.
But you have to look where you're going the whole time. You have to think, can I do
Sort
that?
of like
Can I get up
services.
there?
Coming to terms with a life-changing experience, such as losing a limb, it can have a huge impact on a person's life and the people around them. Sometimes the impact is not realised at the time and is often not dealt with, can slow down recovery and from moving forward. Counselling, I think, comes in sort of 3 stages really. The first stage is about exploration, so exploring all the different issues that they're coming in with. Secondly is looking at options, and quite often there's a lot more options out there than what the person can first see. And then the third stage would be how to put these options into practice and maybe take a different look at how they're seeing their lives at the moment. There are many reasons for people seeking counselling after an amputation. The most common ones would be fear of what's going to happen, how their future's going to pan out, anger, maybe the reasons that they've lost their limb, anxiety, scared, loss of a role, so maybe there were people that went out to work, earned the money, or the mother who has got sort of children to look after and is now sort of immobile. The list can be endless, and no matter how big or small their problems are, they can bring them into the counselling session. And it's not just to do with the loss of the limb, but it's more like a ripple effect, and the loss of the limb can affect all different parts of their lives and the people around them. So the service is open to all the family. For me, what I always sort of say is, if your car's not running quite right, you'd go and get it serviced. So if you're not feeling quite right, how about coming to counselling and just giving it a try? And I think that once most people have come in and had a go, they realise that it's not sort of big and scary, and they're quite happy to come back. But saying that, I usually start off with 6 sessions, and I say to people, if after 2 sessions you can't bear it, then you don't have to come back. If after 6 sessions you think, actually I really need some more, then that's fine, we'll continue until that person feels ready. I do offer children's counselling, which is very creative, and we do that through play therapy and a lot of arts and crafts. And again, the sessions for them can be unlimited, and it's about building self-esteem and self-confidence. And sometimes children come to me and say, I'm different, and it's about exploring all of those things.
But the frightening thing was, getting up and then you're in the parallel bars, and I can picture it. It was quite daunting, actually. It's kind of thing, I've been reborn now, I'm allowed to stand up, and it's a great thrill, actually, to take the first step again.
Part 4 of One Step at a Time takes you through the fitting of your artificial limb and the roles of the prosthetists and the technicians who will make, fit and maintain your artificial limb. John Talbot is a senior prosthetist and is the clinical lead for the artificial limb services at the DSC. John has nearly 50 years' experience in artificial limb fitting, having started out as a technician back in 1967.
A prosthetist's job is to cast the patient. Normally when a patient would come to see us, they would have their stump cast. We would rectify that cast. We would then fit the artificial limb to the patient and realign the limb at that fitting stage. So the prosthetist's job is to measure, fit and cast the artificial limb. It's important to establish that the prosthetist doesn't make the artificial limb. We have a team of 7 technicians here who make the artificial limbs. The prosthetist purely casts, measures and fits the artificial limb. When we do an assessment on the patient, we really try and find out the mobility grade of that patient. The mobility grade would indicate to us how active that patient is likely to be, and this is done with a team of prosthetists, consultants, physios, so we have a good input before we start on the type of activity level that patient is going to achieve. This will vary tremendously from perhaps an elderly patient who has multiple problems, and having a lightweight limb is an important factor. But equally, you can get a very active young primary patient who's very interested in functionality of the limb set against the weight factor. So it would vary tremendously, but the assessment is achieved by a team of professional people. And we would aim to arrive at a common ground of really suitability for purpose. Yeah. What does the patient hope to achieve? At what stages? And we would aim to reach those realistic goals. But they have to be realistic goals. People have a misperception that all they have to do is to put a special foot on a limb and all of a sudden you're running 100 yards in 10 seconds. These are our athletes, full-time professional athletes, and it takes a lot of dedication of these people.
Before the amputation I came here and I spoke to the consultant, the physio and the prosthetic.
Yeah, so the pre-amputation.
So, you know, and they explained exactly what the process was and, you know, their time frame. I wasn't happy with the time frame because, you know, they said it would take, you know, a good 3 years before you're even walking properly, which, you know, I thought, well, that's a bit of a time, but as it was, I pushed and pushed myself, which the physios just went along with it, and, you know, my what can I say, advice on the prosthetic limb has been very good. Because I said that I wanted to be as active as possible, then they accommodated that and tried to pick the best components to give me that option. So again, I've been quite fortunate with that side of things.
We're very much dictated to by can we cast the stump, and it depends on the healing, depends on the trauma of the amputation. Once the team decide that the stump can be cast, after casting we would aim to get the fitting ready for a walking trial within 1 to 2 weeks. This can depend on what type of componentry is ordered. If it has to be a special componentry, then obviously this could delay it by another week. But generally speaking, we would be able to fit an artificial limb to a patient with the appropriate components within a week to 10 days.
Because I said that I wanted to be as active as possible, then they accommodated that and tried to pick the best components to give me that option. So again, I've been quite fortunate with that side of things.
Once we've actually fitted the artificial limb, the first stage is done. Once we're happy that the fit, the length, the alignment are satisfactory for that patient, then to undertake some rehabilitation. They will be referred to their rehab unit, but generally speaking, I would think between 4 to 6 weeks of that undertaking, they could probably or possibly have the limb to themselves at home, but they would only be allowed to, it very much depends on the individual. Once the patient is discharged with their first limb, we would look at 6 weeks for their first initial recall. Now this recall is designed by us to anticipate possible alterations within that first period of time. It might well be that the patient needs to come back before that time. It's not to mean that they can't come back, but we would have a recall after the initial limb being delivered of 6 weeks. After the initial 6 weeks, it could probably be extended to 2 to 3 months. You would actively recall the patient. And this will go on for the first probably 18 months. Gradually those periods of time can be extended. In some cases, patients might need to come in for all sorts of problems before those times, and we're obviously here to fulfil that undertaking. Generally we'd say every 6 months, and certainly at the end of every year, they ought to come in to have their limb checked over.
It was 5 months before I could actually put my leg on again, and probably about 7 months before I could actually walk on it. And I was frightened. I didn't think that I was going to go back to how I was before. So I do understand that sort of aspect of it, because obviously I had to, I didn't realise that when you have had an amputation, you're supposed to sit on a stump board and keep your stump straight, and I didn't do that. So of course when it came round to a fitting of my new limb, I couldn't straighten out my knee properly. So we had to forget the fitting of the new limb for quite a while until I could actually get that knee straightened. And I really did think, oh, my mobility is going to be extremely less than what it was beforehand. But you know, it did come back.
In the early days, one of the issues is the stump volume, and after trauma of amputation, the stump will be swollen. Now you might well have a very successful artificial limb fit, and we would always aim for this, on your first primary socket. It feels very strange to you because you've never had an alien artificial limb on you. Nevertheless, the fit might well prove to be very successful, and it doesn't really prevent you from doing within reason, and people are often surprised at what they can achieve. As time goes by, you will find that the socket will become uncomfortable, and you think, well, why is that? My leg's the same. Well, the only thing that stays constant is the volume of the socket. What varies is the stump that goes inside it, and it will reduce. So if it reduces, you need to have extra packing to pack it out. In the early days, this will be taken up by extra socks. You have an artificial cotton sock, you have a sock that's put on, and then you'd have to add an extra sock, or even an extra sock onto that. And that will take the place of the reduction of the fluid of the stump. Eventually, maybe after, in the early days, 3 months, we would need to put a new socket on that limb. Now, we can line the socket with leather to take up some of the slack, and it saves you wearing multiple socks. So, as time goes by, you will find the time it takes to reduce gradually becomes less and less and less. So the next socket could well last for 4, 5, 6 months.
The prosthetist kept saying to me, you know, it's not so much what's below the knee, it's what you got above, it's the cup. And to begin with, you're not, as an amputee, you're not interested in that bit. You just want something that's going to allow you to do what you did before. So you think, well, it's got to be technology, it's got to be technology. And it's not until, I guess, 2 years down the line, or a year, or 18 months down the line, that you realise that, yeah, those 4 cups you went through, the cup is actually as important as the knee joint and the foot. Yeah, because that's the bit that's touching your skin, and that's the bit that's going to hurt you or allow you to walk. Yeah.
Once that's established, you would hope that for every 6 months a patient could retain the volume of that socket without too many adjustments. Eventually, you would hope that the patient gets established, but it appears that most patients have a comfortable period of their limb wearing that can last 6 months, even up to a year, where they have no problems. Then they'll go through a period of adjustment. For whatever reason, things have altered, it can be a maintenance issue. Nevertheless, the body never stay the same weight, so it can fluctuate and it can vary. But the socket won't vary. Nevertheless, you may well have to start all over again, recasting the patient and starting right from the beginning again. So I would say, how long does it take to get a comfortable fit? It varies, and it will vary throughout the patient's life, where they have very good periods, where they can function very well, then all of a sudden things won't be the same, and they'll battle a bit, and then eventually we'll do something, then you can get back to it. And this is how it appears that artificial limb wearing continues. It's so easy for a patient to put on weight. Unfortunately, they are going to be less active. But in many cases, that can be controlled by sensible diet. It's very unlikely that a patient's going to lose weight by becoming more active. You'll have a good factor, and we would very much encourage any patient to become as active as they can. But it's very unlikely that the activity level of an amputee is really going to have a contributing factor to the overall problem of weight. And weight is very important to retain as much ideal body weight as possible.
You will have bad days. You will have bad days. You just got to go through, work your way through them.
I mean, if you do have a bad day, you've got to talk to people. Don't bottle it up.
You don't cut your family out. That's
just
the worst
thing. Talk to them. You know, if you've got a problem, talk to them. Let them know. You know, and then they'll say, "Oh, let's do this then. Let's do that." It helps. And that's what I found. You know, as I said, I'm no longer the miserable old git. You know, I'm just the old git now. So, you know, because they said, you know, I'm back to playing the fool, if you want. And that's what they want.
Well, you're limited by as much as your mind allows you not to do something. So you only can't do it because you tell yourself you can't. You can do it. There is a way. It's just you may have to find a different way of doing it, but you can do it. You know, don't let people. Actually, yourself is the biggest one. It's this one here. You know.
And frustration. You know, that hit me a lot. I think don't get too frustrated, and if you need help, you can't do it. Ask. Because that's the worst thing, trying to do something, you get yourself all wound up and you just don't want to do it. I don't know, that's how I found anyway, myself. But.
I must be very sensitive because I've only worn shorts once when I went abroad a while ago, and I've never had mine exposed for some reason. And yet, on the other hand, when I went swimming, I didn't bother. I didn't, you know, no leg on. I just went swimming. I didn't bother. But yeah, I must be sensitive about it in a different way.
But I think it's a modern day, isn't it? I think it's open, isn't it? The disability is kind of there, isn't it? And we're very lucky as human beings to be like this in this day and age.
That's right.
And you know, no disrespect, I can understand completely why you feel like that. But I think if, as you quite rightly say, if you're disabled and we're amputees, so be it. I mean, we're still living, aren't we? We're all happy.
Yeah.
We're alive, aren't we?
I'll tell you, as you mentioned that.
It's true, isn't it?
I've been married, we've been married 54 years, and even now she sometimes still don't know which one is the artificial leg. Seriously.
I want to do things I never wanted to do before.
Yeah.
And there's always bit barriers. You know, I wanted to go on an air balloon a couple of years ago and they wouldn't let me because insurance.
Really?
Yeah, because, you know, I can't get myself out of the balloon. Don't know, why worry about that? I lost my arms. You know, I mean, it's ridiculous, you know, but I think I've challenged myself. That's what I feel I can do more. I want to challenge myself.
I mean, it's not just friends and family, is it? I mean, it's other support groups that you can, that are about. You know, there are a lot out there, and providing that you're willing to go and say, yeah, I'm here.
That's right.
They come and talk to you, and
but you don't necessarily learn about them until you start talking to other amputees people.
I mean, you know, the prime example is here, isn't it? The user group.
Mm-hmm.
You know, again with the magazine and that, with all the lists on the back of the magazine saying there's contact numbers for this, that, and the other. You know, no one tells you when you're in hospital.
No, that's right.
That you know, contact these people and contact them. It's one of these things that you've either got to find out for yourself, or when you come here, somebody says, "Oh, have you done so and so?" Well, no, I could do that. And it starts here, then they say, "Oh, we've got a user group." Oh, do that. Then you get that information. And then when you find out bits, you pass that on.
Yeah,
you know, it's part of a big family.
Exactly.
That's what you become of. It's just a big family because, as they said, you're here for really for life. For life. You're in and out of here for life.
That's right. You really do have to be positive. You're still here. That's the main thing. You're still here. There's still people that love you. There's still people that want to care for you, perhaps. And at the same time, you need to use the help that's available to you.